Lepo pozdravljeni vsi prisotni in dobrodošli na današnji webinar. Vemo, da je bolečina najpogostejši simptom v paliativni oskrbi in bistveno vpliva na kakovost življenja teh bolnikov. Predvsem povzroča še tudi intenzivnejše druge simptome, kot so psihološki distres. Razlogi za bolečine ležijo v naravi bolezni in seveda v njenem zdravljenju. In ponavadi se bolečina tudi intenzivira z napredovanjem bolezni. Novejši epidemiološki podatki kažejo, da je še veliko prisotna med temi bolniki. Snedeljeva je najdla nekje manjši procent kot desetletja prej, ampak še vedno okrog 50% teh bolnikov ima stalne bolečine, ki so ponavadi srednje močne in močne. Zanimiva je študija Rama, ki je preučil v Nemčiji bazo podatkov za paliativno oskrbo in je ugotovil, da v paliativno oskrbo vstopa 50% bolnikov z neobvladano bolečino. Po obravnavi bolečine pa kar čez 70% teh bolnikov je imelo učinkovito olajšanje bolečine. To pomeni, da še vedno nismo zadosti učinkoviti in da moramo narediti dosti več v edukaciji in v obvladovanju bolečine. Glede na jakost bolečine pa vemo, da je ta bolečina srednje močna in da so izbirna sredstva opioidi, ki se morajo uporabljati po določenih principih, da so dejansko učinkoviti in ne povzročajo neželene učinke. Današnje srečanje je s poudarkom na poznavanje farmakoloških lastnosti, na pravilnem uvajanju in sami izbiri opioida, ter poudarek na prepoznavanju in obvladovanju neželenih učinkov. In to je dejansko steber učinkovite in varne uporabe opioidov. Današnji predavatelj je profesor Frank Ferris, ki prihaja iz San Diega, je direktor iz medicinske edukacije, deluje v Elizabethinem hospicu v tem mestu in moram povedati, da je večni popotnik po celem svetu, kjer praktično širi znanje in svoje izkušnje iz paliativne oskrbe. Je vabljen profesor v Peču, v Tbilisiju in različnih drugih mestih, pa tudi v Sloveniji je bil večkrat, zlasti pri nas na mariborskih srečanjih. To bi bilo za uvod, sedaj bi prosila, če je mogoče profesor Beovičeva dosegljiva za njeno pozdravno besedo. Ona je nekjer na poti in je možno, da se ne bo uspela javiti. Jo imamo ali ne?
Trenutno predsednice še ni.
Nije, ok. Dobro, pa gremo kar naprej na temo današnjega srečanja, ki bo potekala naprej v angleščini, zato predlagam, da tudi nadaljujemo v tem jeziku. Vkolikor želite postaviti vprašanja v slovenščini, ni problem, bomo to profesorju prevajali. Sedaj pa bi naslovila še samega profesorja. Dear Professor Ferris, welcome. Very warm welcome to Maribor, to Slovenia again, and to this webinar under umbrella of Medical Chamber of Slovenia. In the introduction, I mentioned the importance of knowledge on opioids for providing effective and safe analgesia in patients in palliative care. I also announced you as a world traveler who spreads knowledge and experience about palliative care all around the world. It is our pleasure that we have you today, and please, the floor is yours. We have about more than half an hour, 2 hours for your presentations, for discussion, and for answer to questions of the audience. Please, the floor is yours.
Nevenka, thank you so much, and what a delight to be with you. Gregor as well, and to everybody present, I'm delighted to be able to share some concepts with you. Really about dosing principles, although we will focus on analgesics, the concepts apply broadly across healthcare. Let me share my screen so that you're able to, everybody see it, and then let's begin. My goal would be to chat for maybe a little more than an hour to share the content with you, and then to invite questions. So please keep your questions and let's have a dialogue. I have nothing to declare. I have no particular interests. I have no particular funding beyond the standard. Nevenka highlights that I do get to travel. I've been in 45 countries over the last 20 years and delighted to have been in Slovenia each of the last 2 years and look forward to being with you again this coming fall. You're welcome to use my presentation to share it widely. I know we are recording this session. Please share it with all your colleagues. Use it to teach your residents. I also want to thank very much Gregor and Nevenka for this opportunity and creating it, and for the House of Medicine in Slovenia. So my first comment is, although I'm going to be talking about analgesic dosing principles, it's a model for the way we prescribe most medications, not just in palliative care, but also in medicine in general. Let me start out with a story. This is about Bill, a patient I met many years ago. He was a war veteran. He was diagnosed with cancer in his prostate. By the time I got to see him 3 years later, he had metastatic disease. And when I met him, even though he'd had radiation therapy to several of his bone metastases, he was still experiencing severe pain that he described as a toothache, as well as pain shooting down his legs, consistent with mixed nociceptive and neuropathic pain. He rated it on a numerical rating scale as an 8 to 9 out of 10. He said it was like a G-clamp, one of those clamps you put on furniture to hold pieces together if you're gluing them. And he said you'd be yelling your bloody head off. And I looked at him and I said, and if we didn't control it? There was a long pause. And he said, oh my God, life would not be worth living. I'm sorry. His legs were cold and numb. He said, the problem with pain is you can't see it and people don't believe you. So the question is, if you have pain that's 8 to 9 out of 10, should I be believing you? And I suspect you would say, absolutely. Well, don't we need to believe Bill? So many of us would say, oh my goodness, what about if he's confabulating? Let's start out by trusting our patients from the outset. And even though he says his pain is 8 to 9 out of 10, let's believe him. Now, many years ago, because there are no randomized controlled trials, and there never will be, a group of experts got together in Geneva through the World Health Organization and developed this tool, which is called the WHO 3-step ladder. Now, the idea was not that we would start at step 1 and move up the steps, kind of like we go up a ladder. I would have found it more effective if they'd called it the 3 groups of analgesics. Because what they did as experts was they said, well, let's put all the mild analgesics, such as paracetamol, the non-steroidal anti-inflammatories, aspirin, into group 1. Let's put all the moderate strength analgesics, such as codeine or tramadol, or combinations of paracetamol with tramadol or other products, in group 2. And let's put all the strong analgesics, of which morphine is the model, but we also have oxycodone, fentanyl, methadone, in group 3. And then they said, based on the grouping and then the patient's self-report start with either group 1, if the numerical severity score is 1 to 3, relatively mild pain. Let's start with group 2, if the analgesic numerical score is 4 to 6 for moderate pain, or if the patient reports 7 to 10, let's start with group 3. Now you might be saying, oh my goodness, Ferris, that's a lot. I can promise you, based on my 39 years of experience working in palliative medicine, and before that in oncology, dealing with lots of patients and using this tool, this is absolutely the most appropriate, and I'll be explaining why. So for Bill, with his 8 out of 9 pain, even though he's never had an analgesic, we should start with group 3. Well, you might be saying, well, I'm worried. Well, you and I need to recognize there are side effects, but constipation, it is a primary effect, as well as the urinary retention, which is not very common. We expect almost everybody will get constipation because of the actions on the bowel. Nausea and vomiting can occur in folks, ladies, more common than gentlemen. We don't really know why. And the uncommon side effects, things like bad dreams, hallucinations, the delirium, really don't happen very often. Now, many of you may have been taught that you should be really worried about respiratory depression. And it is true that we should screen for apnea or somebody who has, well, I'm just drawing a blank, apnea or, drawing a blank, sorry. Respiratory depression is just not that common. Oh, I'm sorry, apnea and obesity. Respiratory depression is just not that common. And in fact, I'll be teaching you a technique which means that you're unlikely to see it at all. I've seen it only a couple of times in my entire career. So we have Bill in front of us, and we need to understand how to prescribe medication to manage his pain. Now, I will point out that I've used a cancer with bone metastases for my model. I'm not teaching pain management today. I'll be very clear, many different types of pain are not responsive to opioids at all. That would be a completely different discussion. What I'm really doing is teaching pharmacokinetics and how to dose medications. So how many of you from your medical school training remember first order kinetics? We all learned it, but I suspect most of us whizzed past it to more complex concepts, and then we forgot about it. But this is the way most medications behave. We give a dose of medication and we get absorption into our bodies. As absorption increases, we get an increasing plasma concentration, and the symptom that we're trying to manage, if it's the right medication, decreases. So with morphine, the pain goes down. Now, concurrently, the risk of side effects goes up, doesn't it? And of course, the peak analgesia and the peak risk of side effects will be at the maximum concentration. Once we get past that on the curve and we start to get elimination from our bodies, the pain starts to increase again, and the risk of side effects decreases. Depending on the dose we give, there's a proportional increase in plasma concentration. Our goal is to try to keep Bill's pain under control. Now, the principles that I'm teaching, of course, apply to the analgesics, except methadone, which has completely different pharmacokinetics. And most of the medications used in palliative care and medicine in general follow first order kinetics. as well as the risk of side effects. So let's start out with, how do we dose for that extra or breakthrough pain? Well, the principle is we should offer an extra dose once every time to maximum concentration. Whether you use PRN or SOS in your prescriptions, it doesn't matter. It's the same concept. So what does PRN mean, or SOS? It means dose as needed if the pain is not well controlled. Of course, the patient can refuse, can't they? So looking at this curve, the maximum analgesia occurs at the maximum concentration. If we're giving an extra or breakthrough dose, we need to wait the full time for the dose we've given to reach that maximum concentration. That concept is called the time to maximum concentration, or Tmax. It's the time to greatest analgesia. And the reason we wait is we want to ensure that we've waited for the possible risk of side effects. We don't want to move any faster. Now, you might be saying to me, well, do I need to know the data? And absolutely. We will be providing you with pharmacokinetics tables. All of this information is available in the pharmacokinetic literature. Whether it's lexicomp or micromedics that you're looking up, the data is all well known. You can't license a medication without this information. Now, it turns out if we use morphine orally, and the same is true for most medications, the Tmax is 60 minutes. Now, if you're a purist and a scientist, you might be saying, well, not everybody's the same. It's true. In fact, there's a range. For oral or rectal morphine, it's 45 to 60 minutes. Just to illustrate the point, we're going to ask you to wait in everybody 60 minutes because we want to make sure everybody is safe. Well, is it any different subcutaneously? Well, of course it is, because now we're putting it under the skin and we're avoiding the oral absorption process. It's faster, and the maximum concentration is 20 to 30 minutes. We're going to ask you to wait 30 minutes. And of course, if we put it in intravenously straight into the vein, its absorption is faster. But remember, it needs to move from the intravascular space across the blood-brain barrier to those neuroreceptors that are inside our cerebral spinal fluid. So it still takes some time. In some patients, it may be a little faster than 15 minutes, but particularly with patients with poor cardiovascular output, the elderly, as one example, we're asking everybody to wait 15 minutes. You might notice it's 60, 30, 15, and I would ask you to memorize those numbers. This absorption process is similar for most medications. So even if I asked you, what is the time to maximum concentration for subcutaneously administered midazolam, it's 30 minutes. If I asked you about intravenous haloperidol, it's 15 minutes. It's just about the absorption process. So please memorize those numbers. Don't move faster. You don't want side effects. So the backdrop is that for extra or breakthrough pain, we offer an extra dose once every time to maximum concentration. And of course, the patient can refuse. And please never, never, never use extended release products for the purposes of titration or breakthrough. I'll be explaining why a little bit later, but they're simply not appropriate. So what does it look like if we give an extra dose? Well, let's imagine that's Bill. We've given him a dose. His pain is still not controlled. He takes an extra dose. The plasma concentration goes up a small amount. And a little bit later, I'll be talking about the size of the dose that we should choose. The point is, offering people the option for extra or breakthrough doses allows them to have control. Wouldn't you want that for yourself? I'm sure most of us would say absolutely. And of course, recognizing it's once an hour, my goodness, if the patient was really fastidious, they could take a dose 24 times a day. Now, of course, most people won't because they have the same fears about these medications that you and I do. They've heard about it. You know, it's the M word, morphine. My goodness, don't want to use it. But if they took 4, 6, 8 doses, that would be terrific. What we need to be sure is that we provide them with a prescription with enough tablets or liquid so they could get their pain under control in a timely manner. Because I suspect most of you would say, oh, I want my pain controlled in a few minutes or certainly a day. Well, they will as well. And this is the way forward. Now, of course, what happens if we only offer it every 2 hours? Bill starts to slide down that curve. His pain starts to return. You're prescribing it because you're anxious, not because it's going to help the patient. We need to offer it once an hour if it's oral, as needed for the patient. And of course, as I've said, the patient could have a dose once every hour, and they could take 24 doses. So the second principle is, what do we do for constant pain? Well, we should be dosing this routinely once every half-life. So of course, you might be saying, what's the definition of half-life? Well, it is the time that it takes to eliminate half of a given dose from our bodies, whether we pee it out in our urine or we inactivate it by our livers. So here's an example. If we give 10 milligrams of morphine, what is the time it takes until half has been eliminated so that still 5 milligrams remains in our body? It turns out this is about elimination, not about absorption. So it's independent of the route of administration. The half-life is 4 hours. And of course, there's a bit of a range, but we've chosen 4 hours, and it's used pretty universally around the world. So the concept is dose once every half-life to achieve steady state for constant pain. So how many half-lives are there to achieve steady state? Well, it turns out it's 5. The half-life is 4 hours. We dose again at 4 hours. We dose again at 4 hours. And you can begin to see how close we are rising to get to steady state. Now, you might notice that with 3 half-lives, we're almost 90% of the way there. But I encourage you not to rush if you're doing this, particularly in the outpatient or home environment. Give people a chance to get to steady state before making adjustments, because they could still get the onset of side effects. And the most likely side effect they'll experience, besides the constipation and the nausea, is the onset of some drowsiness. And once people get drowsy, if they continue to be drowsy, my experience is they often say, oh, I don't want this medication again. So please just wait. Now, if we were to start Bill at 10 o'clock in the morning, because it would be 5 half-lives, each one is 4 hours, he would be at steady state 20 hours later, which would be 6 o'clock tomorrow morning. So of course, we don't have to wait. It isn't going to get any better. We should invite either our nursing colleagues, our pharmacy colleagues, or ourselves to phone the patient and find out how they're doing one day after they start. It won't get any better. Ideally, what we're hoping to achieve is that our routine peaks and troughs are within the therapeutic index or therapeutic window. What does that mean? It means we hope the plasma concentration is above the level needed to control the pain and below the concentration where side effects occur. Now, for many patients like Bill, we don't know where we're starting, so it's going to take us a day or two to get up there. And that's where we'd like to remain. That's our goal. Now, what are the kinetics for other similar analgesics? Well, they're actually the same. Paracetamol, Tmax is 1 hour, half-life is 4 hours. It takes 20 hours to get to steady state. Yes, we might start with a low dose, but you and I need to recognize that the now recommended maximum for paracetamol has been dropped to 3 grams per day. Sure, if you've got a product with 3.25 grams total, that's going to be fine. But be careful. And because this is one of the risk medications that can be leading to really bad side effects, including I've had a couple of patients take an overdose and die, warn your family and your patients not to take too many tablets. If you have a 500 milligram paracetamol tablet available to you, that's 6 per day. And if Slovenians are anything like Americans, if 1 or 2 works, we love to take more. And of course, we can buy these over the counter. Ibuprofen, one of the standard non-steroidals, has similar kinetics. You'll notice the Tmax half-life is the same, 20 hours to steady state if they're taking it routinely. Also now notice that the now recommended maximum is basically 3 grams per day. Immediate release morphine, I put the table up again to show you because there is no upper limit to the maximum. We either titrate to great pain control or side effects that prevent us from titrating further. Be careful. Many people get upset by the numbers, but the patient's pain is not yet controlled. Don't worry about the numbers. Early on in my career, I had patients who were taking large doses, and by my large doses, I mean 1 gram an hour of oral morphine equivalents, so 24 or more grams per day. Terrible, disgusting disease. We didn't have all the co-analgesics we had today, but they had no side effects, and their pain was mostly under control. Well, you need to learn the exceptions. And I'm very aware that you have a lot of tramadol use in Europe, much more than we have in North America. Recognize that this medication has different kinetics and you need to memorize these. The Tmax is 2 hours because the medication needs to be metabolized in our livers before it becomes active. You'll notice that the half-life is 7 hours. We typically dose it once every 6 hours for convenience. So the steady state will take 1.5 days. We can't adjust it once a day. We're going to adjust it probably every 2 days. And notice that the therapeutic window is very narrow. Yes, you might start out for constant pain with 50 milligrams every 6 hours, but you can't go any higher than 100 milligrams every 6 hours, a total of 400 milligrams per day, because there's a high risk of side effects that are very different. The serotonergic syndrome is quite a problem. You can see all the possible things that can occur for patients. It's very unpleasant. And what I'd like to highlight is, in fact, the action of tramadol is cocaine-like. It can actually cause coronary artery spasm. When I was traveling in Gaza, I learned that young people who were abusing tramadol, 2 or 3 were coming into their emergency departments every week with these myocardial infarctions. and on vascular catheterization. Their vessels were clean. It's where we learned about the cocaine-like artery spasm. It occurs in several countries, I've learned subsequently, where they don't have access to alcohol or other opioids. So what I'd like to highlight for you is the simple kinetics. I'll be sharing a reference card that we've created, asking you to memorize 5 numbers. The time to Tmax, 15, 30, 60, IV, sub-Q, oral, or rectal, the half-life of 4 hours, and the fact that it takes 5 half-lives to steady state. As I mentioned, you probably would like to get your pain under control quickly. So would your patients. Don't make them wait extra days. Do it as quickly as the pharmacokinetics will allow. I'm also going to be providing you with medication tables, and on those tables we have pulled out all the data. Yes, the first column is the name of the medication, the middle column is the time to maximum concentration, and the right-hand column is the half-life. You'll notice there are numbers in brackets. Those are the pure data out of the pharmacokinetic tables. The number out front is our recommendation of what to use for dosing on a day-to-day basis. Okay, so we've talked about the kinetics, and the concepts apply to almost every medication we use in medicine, in fact. But let's get down to practical. How does this work? Well, you've got Bill sitting in front of you. What sort of a dose should I start with? It turns out that this particular table also guides us regarding oral morphine equivalents. You might notice that paracetamol, maybe it's 500 milligram tablet, it has an oral morphine equivalence to 1 to 3 milligrams of oral morphine. That probably surprises you. Or ibuprofen, 400 milligrams, is the same, 1 to 3 milligrams of oral morphine. We haven't talked about this in medicine, but it is a reality. These all actually have some equivalence to morphine. The second level for moderate pain, the pain score is 4 to 6. It turns out these medications have about 4 to 6 milligrams of oral morphine equivalents. And particularly if I look at tramadol, 50 milligrams, it's approximately 5 milligrams of oral morphine. So if I look at the combination product that you have of paracetamol with tramadol, it's going to be 5 or maybe 6, maybe 7 milligrams of oral morphine equivalents for one of your combination tramadol with paracetamol. You're probably surprised, but of course we give tramadol out a lot. We give other combination products a lot in America. And what we know is patients, they typically don't get into trouble, do they? They might have constipation, that's normal. They might have a little nausea, that's normal. But most of them do fine, particularly if they have strong pain. So again, you can see the score 7 to 10. If we're going to start somebody with 8 or 9 out of 10 pain, maybe we need to start with 10 milligrams of oral morphine. So that would be my recommendation. Now, 2 scenarios. The first scenario is Bill arrives, he's never had an analgesic. So he's naive, particularly to the opioids. We don't know what he needs. Even though he has constant pain, please only start prescribing a breakthrough dose and teach him how to use it. So I would give Bill morphine, immediate release tablets, not the extended release. I'd offer 10 milligrams by mouth once an hour, PRN or SOS. Now, remember, that isn't even the equivalent of 10 milligrams of tramadol. In my world, it's not the equivalent of a Vicodin or a Percocet tablet that we use a lot of. It's not very much at all. Now, you might still be worried, so of course you can start lower if you want, but remember, you're starting with a lesser dose and you're likely going to make the patient wait longer to get their pain controlled. But you can give a dose and you can watch and you can see what happens. For patients like Bill, who are well-nourished and reasonable, but still have bad disease, the 10 milligrams is probably going to barely touch their pain. So we send them home with the 10 milligrams. We encourage them to take it once an hour, and we follow up a day later to see what they've taken. We use what we call a catch-up technique. If Bill is opioid tolerant, so let's assume he comes in taking tramadol, it's gotten up to that 100 milligrams every 6 hours. So 400 milligrams in 24 hours. He's still in 8 to 9 out of 10 pain. We calculate the equivalence in morphine. It's 10 to 1. 40 milligrams of morphine every 24 hours by mouth would be the equivalence. The recommendation is for patients in severe pain, double what they've already been taking. So in this case, it would be recommended 80 milligrams of oral morphine in 24 hours. Now you need to offer it once every 4 hours, so divide by 6, not very easy. Let's just make it 90 milligrams. Divide by 6 makes morphine immediate release, 15 milligrams every 4 hours by mouth. That's the routine because they've been taking it routinely. In addition to that, what we need to do is offer a breakthrough dose. So how much do we offer? The recommendation is 10 to 20% of the total dose that you will be offering routinely in 24 hours. To do that, you can simply divide by 6 if you wish, and we offer it once every Tmax. Of course, the patient can refuse. So what does that mean for Bill if he's taking 15 milligrams every 4 hours routinely? That would be 90 milligrams in 24 hours, which would give us 10 to 20%, would give us 9 to 18 milligrams every 24 hours in the range. Well, 15 milligrams is exactly the same as the routine dose. Let's offer the same tablet. One he can take every 4 hours. One he can take every 1 hour PRN. Now, Bill won't remember what he did for the last 24 hours. I don't know about you, but I often forget what I've done as well. I want Bill to keep a pain diary, and I want Bill to record information every time he takes a dose. My first question is, did he record the last dose that he took? How severe is his pain now? And is he having any side effects or any effects he doesn't like? If the answer to the third question is yes, he is, then I want him to call the nurse or the doctor. I need to teach Bill how to do this. So I'm going to illustrate with a simple 24-hour clock. Remember, my prescription is up in the upper left corner. It's 15 milligrams every 4 hours by the clock and 15 milligrams every 1 hour if the pain score is unacceptable. So if I give Bill the first dose at 10 o'clock in the morning of 15 milligrams, if his pain is still out of control, an hour later he could have an extra dose, a breakthrough. If an hour later his pain is still out of control, he could have an extra dose. An hour later, he could have an extra dose. I want him to wait the hour before he moves, but at the hour, he's welcome to take an extra dose. And then we get to 2 o'clock. It's 4 hours later. Oh, by the clock, he's supposed to take 15 milligrams. And if the pain is out of control, he is welcome to take a breakthrough. So he can have 15 plus 15, a total of 30 milligrams at 2 o'clock. And then he would continue on with breakthroughs for the next 4 hours until it's time for the routine dose. Now, most of us don't remember when it's 4 hours, so we clearly need to set some kind of an alarm. It's the beauty of our smartphones these days, which allow us to actually set the clock and have it ring. What's his pain diary going to look like? Well, here's an example. 10 o'clock, 11 o'clock, 12 o'clock, you can see his pain severity scores, and you can see the dose he's been taking. 15, 15, and then at 2 o'clock, he takes 15 plus 15. I insist my patients who are trying to get their pain under control use a pain diary. I will not change the prescription if they don't use a pain diary. So they've now started to keep the pain diary. How do I change the doses? I used to be thinking I was smart. I would look, and let's imagine Nevenka, who's sitting there, as having pain. I would look at Nevenka and I would say, oh, I think you need 25 or 50% more analgesia. I can see you're suffering. That's what I'd like to do. Big mistake. I got plenty of patients who were drowsy and they didn't like the medications and they didn't want them anymore. So now I've learned that I need to allow the patient to take the breakthrough doses, and for me to change the routine dose, I need to catch up with what they've already demonstrated was safe. I want you all to always be safe. And as I pointed out, I'm using morphine as my model because it's a great illustration of how to do this. But this technique applies with every medication that you and I prescribe. We might be using haloperidol to control the delirium, and we don't know what to start with, so we just give some breakthroughs. But once we've calculated the total usage, then we can go to routine dosing. We might be using this for a benzodiazepine to create sedation. Again, we can titrate to find out what we need to create the desired sedation, and then we convert to routine. So what does this look like? We sent Bill home with that prescription of 15 milligrams every 4 hours by the clock. You can see here he took it routinely, all 6 doses. When he read his pain diary, I could see that. We invited him to have 15 milligrams, and he took 6 breakthrough doses as he needed it, another 90 milligrams. A total of 180 milligrams he consumed. Now you remember his pain score was 8 to 9 out of 10. Well, now it's dropped a little bit. Maybe we forgot to ask him what his goal is. We need to make sure we know what the patient's goal is. Never assume it's 0. We need to ask. In Bill's case, it was, I'd love to be a 2. I haven't been a 2 for months. Okay. Is he at goal? No. Is he having any side effects? Nope, no side effects. It was safe. And in fact, we're doing pain management in order to help Bill have a better quality of life. Has he been moving around a little bit more? Did he sleep better last night? Is he eating any more? What's his mood? Those are all questions we need to ask. They can really help us see, are we having the effect we're hoping for? Because of course, Pain management is about giving people back the life they want to have. So the total for Bill after 24 hours was 180 milligrams was used. That becomes the new routine. We catch up. So we divide by 6. The immediate release would become 30 milligrams every 4 hours by the clock. And we take 10 to 20% of that 180. Again, right in the middle is another immediate release of 30 milligrams every 1 hour PRN or SOS. I'm hoping this makes sense to you. Glad to debrief it further in the questions. We follow up the next day. Again, if he has not kept his pain diary, I will not make any changes. I don't want Bill to be thinking, oh, maybe I took this, maybe I took that. He has to read his pain diary. Could be that he reads it to the nursing colleague, to a pharmacy colleague, somebody who's a reliable team member, all fine. I need to know the summary of what he actually took. And I need to know what his pain score was. Well, look, it came down a bit further. Now it's 4 out of 10. How's your sleep? Well, it was a little bit better last night. Your activity? Well, I had dinner with my wife and we sat up for a bit and watched a movie. I was able to go for a short walk in the garden. I haven't been able to do any of those things for a while. Any side effects? No. Just the constipation, and we're trying to manage that with the laxatives that you've given us. Read your pain diary. Notice he took the routine doses all on time, 180 milligrams. He took the extra or breakthrough doses, only 4 of them. Wow, not 6. He didn't need quite as much, 120 milligrams. Total is 300 milligrams. We're not at his score that he hoped for. His activity is improving, but not perfect. And he had no side effects. It is safe for us to catch up. So the new prescription becomes 300 milligrams divided by 6, gives us 50 milligrams of immediate release morphine every 4 hours. And the breakthrough, 10 to 20% of the 300 milligrams, 50 would be right in the range. Let's give him the same tablet format to use every 1 hour PRN or SOS. Day 3, it's the same ritual. My goodness, look. He says, well, my pain score is a 2 out of 10. In just 3 days, we've gotten it under control very safely. And he didn't have any side effects. So read the pain diary. 50 milligrams, all 6 routine doses, taken right on time. He only used 2 breakthroughs. Total is 400 milligrams. Again, that becomes the new routine, dividing it by 6, gives us 65 milligrams of immediate release morphine every 4 hours. And the breakthrough can be exactly the same. It's right in the range of 10 to 20%. Now, I suspect most of us would say, "Oi, you're asking me to take medications every 4 hours, including in the middle of the night? Ferris, you're crazy." Well, no, I'm not crazy. I'm following the pharmacokinetics. But of course, it's unrealistic, isn't it? Especially with patients who've been in bad pain. They probably haven't been sleeping for several days. They're going to have exhaustion. They're going to want to catch up. What do you mean, set the alarm clock for 2 o'clock in the morning? Craziness. Fortunately, our pharmaceutical industry has prepared extended release preparations for us. These are tablets that are manufactured with a different dispensing strategy. It's the same molecule inside. It's just morphine. It's just the tablet breaks down slowly. In fact, we can look at the kinetics of these medications. Here's morphine, 120 milligram by mouth every 12 hours, just as an example, the peak occurs at 2 to 3 hours. The dosing interval is 12 hours when they hit the trough for this particular tablet size. Now, what I want to emphasize is the dosing interval is a concept similar to the half-life, but it's not the same. The dosing interval is based on the pharmacokinetics of the extended release product. These products are wonderful to help us with adherence and compliance. You only have to take it twice a day. Even I can remember how to do that, certainly as long as I put them out and remember. The reason they are not appropriate for titration is you have to wait 5 dosing intervals to get to steady state. Well, that's 5 times 12 hours is 60 hours. That's 2 or 3 days. You don't want to sit in pain waiting for that. Not at all. These are maintenance products once we've achieved control. And for titration, we'll still add the immediate release morphine products. Now, what's very important is that we shouldn't crush or chew these tablets. And what we do know is that some elderly people still do chew them. What I want to reassure you is we have even a 200 milligram size sustained or extended release product of morphine in the US. If an elderly person chews them, they get all the morphine at once. There is no way our Food and Drug Administration, knowing this risk, would ever license a tablet that was dangerous. Even if a patient gets an extra 200 milligrams as a bolus and they're opioid tolerant, they're not going to die. They're probably going to have a good sleep, but they're likely not even getting respiratory depression. I've actually only seen respiratory depression twice in my 39-year career, and I could have predicted it in the 2 patients who got it. We didn't stop the opioid use, we just monitored them very carefully, and we caught the respiratory depression quickly. So know that these tablets are safe, even if they're crushed or chewed. Back to that little diagram. Again, recognizing now you achieve steady state at 60 hours, 2.5 days. You can't adjust faster, but also know this again, no ceiling. You titrate to effect or side effects. And given you're using these for maintenance, you're really only catching up with the use that's already been demonstrated as safe. So, at day 3, instead of giving Bill immediate release morphine, which would just mean another dosing in the middle of the night, let's convert him, because his pain is 2 out of 10, let's convert him over to the long-acting. We calculated from his pain diary that he was taking 400 milligrams. Now, instead of dividing by 6, we divide by 2. We give him extended release morphine, 200 milligrams every 12 hours. And then we add an immediate release product for the breakthrough. It still does 65 milligrams of immediate release morphine every 1 hour as needed, or SOS. Now you might be saying, well, Ferris, we don't have exactly the same tablet sizes as you do. Fine, just adjust up and down to account for the tablet sizes you do have. Now, the reality is some patients cannot afford the extended release products. We have this problem here in the United States. I know you may have a different payment structure in Slovenia for medications, and I think you are very lucky to have that, particularly for people with advanced illness. But I want to illustrate what to do, just in case somebody can only afford the immediate release medications. I was very surprised. The concept that we need to be looking for is food insecurity, and the idea means the patient can only afford food or accommodation or medications, we actually have a pretty high rate of that. And you might be surprised in America that that's the reality, but it is. So what do? They've got good pain control using the medication every 4 hours, but I don't want them to wake up at 2 o'clock in the morning. How can I avoid that dose? The secret is offer a breakthrough dose at bedtime. It gives them a double dose. It's exactly what they've been using for their breakthrough, and they'll sleep through the 2 o'clock in the morning dose, and they'll wake at 6 o'clock with the nadir, but it's time for another dose of medication. It will get them through the night. It's a simple trick. Now, if on day 18, Bill calls and says, my pain's bad again, what you and I need to recognize is tolerance is not a clinical reality. For patients with stable disease, we've actually had them on the same dose of medications for months, even some over years. When people call, particularly when we know they have underlying disease that can progress, the most common reason for increased pain is disease progression. Even though it might be slow with cancer of the prostate, it still occurs. So Bill's pain is now up to 6 out of 10. He doesn't have side effects, so he took 5 extra breakthrough doses. It was safe, but we need to recognize that we need to increase the routine dose to catch up. Total dose becomes 725 divided by 2. 720 is easy, 360 milligrams every 12 hours. And now the breakthrough right in the middle of the range, 10 to 20% would be 100 milligrams every 1 hour PRN or SOS. Now, I wonder if any of you are sitting there and saying, oh my goodness, those numbers, they're too high. I've never been up there. Well, you may not have been. But everybody's different. What I want you to understand is from the literature, as we have it, and it's actually not very good in this area, what's the normal for patients with metastatic cancers? They tend to be in the 200 to 600 milligrams of oral morphine equivalents per day. Of course, some are less, and some are more. Some, as I've described, can be much, much more. And as I said to you, I'm not teaching pain management in this session. I'm teaching kinetic principles. Of course, we would be thinking about other medications. That would be a separate talk. One last concept, then we'll stop for questions, which is let's talk about clearance concerns. You and I need to adjust medications for changes in the way we metabolize or clear those medications from our body. Now, we need to recognize that in the opioids, morphine, hydromorphone, oxycodone, hydrocodone are all water-soluble. Fentanyl and methadone are fat-soluble. The water-soluble opioids flow in our urine. The fat-soluble opioids are inactivated by our livers. So what happens? Well, it was with kidney transplantation that we began to learn how this really works. And when I started my career, we didn't know this. What we've learned is that morphine is conjugated into morphine 3-glucuronide and morphine 6-glucuronide in our livers. Tends to be a little more morphine 3 produced when it's given orally, but that's not universal. The conjugation, the glucuronidation, occurs in our livers even when there's very significant hepatic failure. So even in pretty advanced cirrhosis, we've seen this continue. But of course, in our patients with metastatic disease, their livers may be functioning absolutely perfectly, even if they have components which have metastases. What we need to recognize is that these two products have different effects. The morphine 3-glucuronide is responsible for the majority of the problematic side effects. The central nervous system excitation, the hallucinations, the delirium, the drowsiness, what may turn into myoclonic jerks, even seizures. The morphine 6, on the other hand, it's a terrific analgesic and not really responsible for a lot of side effects. In fact, the reality is the kinetics I've been teaching you are the kinetics of morphine 6-glucuronide. That's the way it in fact works. So there's a differentiation in these two products, and we need to be careful, but we can also ensure analgesia even if we are not giving more tablets, as long as their molecules are still in our body. So how do they clear? Well, the majority of all three products, morphine, morphine 3-glucuronide, and morphine 6-glucuronide, are eliminated by us peeing them out. Now, what I like to illustrate is morphine just thinks of us as a bucket of water. If I can just illustrate with my fingers as though it's a bucket. We put it into the bucket to create a concentration to control the pain, and we pee it out. We put it in because we got to catch up on what we pee out. We put it in every 4 hours because we eliminate it every 4 hours. If the elimination stops, if we keep putting it in, we will overfill the tank. We already had good analgesia, but now we'll start to accumulate the morphine 3-glucuronide. If we keep putting it in, if there's no elimination, we will create central nervous system excitation and real problems. Early in my career, when I didn't know this, I made terrible mistakes. So what's an example of a situation where the morphine clearance stops? Well, if patients have oliguria, that could be dehydration, renal failure, or the dying patient. My goodness, we need to think about adjusting. It turns out that we need at least 500 milliliters of urine out per day to clear our toxins. So arbitrarily, I've said if we have less than 500 milliliters per 24 hours, let's decrease the routine dose by 50%. If we have less than 250 milliliters of urine or no urine output, please stop the routine dosing. You can always continue the breakthroughs or PRN or SRS doses. What you don't want to do is give a patient who has no urine output extra morphine. You've already got analgesia. You don't need more morphine 6. What I like to say to families about patients who are dying, they're going to have analgesia until death because they're not clearing their product. But I don't want to put more in because I don't want to create the central nervous system excitation. It's horrible. So let me just complete my story about Bill. He made me promise that I would close the story if I was teaching with his story. I came back a few weeks later to see him, and unfortunately, he'd developed a spinal cord compression. He was incontinent of urine and stool, and he had quite a bit of weakness, but he was still able to get out and about with assistance from his friends. Yes, he had good pain control. You can see the dose was about 360 of routine morphine each day. With breakthroughs, he was using about 4 per day. And of course, he had some co-analgesics. When to use those would be part of a different talk. While I was there, his friends came in, they opened up a bottle of wine, and they all raised their glass, and they said, please say to the doctors and the nurses and the pharmacists, thank you for listening to the patient. Thank you for listening to me. You gave me back my life. I'm able to live again. Before, when the pain was miserable, I couldn't do anything. I was just thinking about the pain. The reality was Bill lived for several more months, out and about with his buddies, and then because of the great palliative care, he died quietly at his home. And the reality was he didn't change his morphine doses that much more. And at the end of life, we did stop the routine doses to make sure we didn't throw him into an agitated delirium. And he died quietly at home. So I'm hoping what you can hear by us talking about analgesic dosing principles is that pharmacokinetics are foundational. Please use those to dose and guide analgesic use. Follow my catch-up technique. You will control the pain as rapidly as reasonably possible, and you will be safe. Remember, every breakthrough dose is a test of efficacy and safety. If a breakthrough dose gives us side effects, we need to pause and certainly not escalate further, determine what's happening. Of course, if you get into large doses, it may be appropriate, if you're a generalist or not that familiar, get one of your palliative care colleagues to join you. Through experience, you will begin to learn just how to do this, and you can really get patients' pain under control quickly and safely. And if you take the techniques and apply them to other medications, whether it's the antidepressants, the antipsychotics, whether it's our benzodiazepines or many others, the same principles apply. The table that I will give you will have all the data. You will get symptoms controlled efficaciously and safely. I look forward to comments and questions. And just as I finish up, I'll put out the challenge. You and I are going to be the prescribers. We're going to be doing the modeling, but one day it's our turn. You can see that I'm not a young boy anymore. I'm moving on in my days, and I've spent a lot of time making sure the care in my community would be the care that I would hope for. Will that be true of Slovenia? That's the challenge. But it's your turn. Will Slovenia be ready for you? I sure hope so. I look forward to your comments or questions.
Okay, so far there are no questions. There was only one question about therapy for prostate cancer, but it was just about therapy, not about pharmacology of opioids. So I answered that very quickly. Maybe one question in the beginning. If you can tell us how long usually it takes when you titrate immediate release opioid to change that to slow release.
Right. So you could see in my illustration, it was 3 days for us to get Bill's pain settled. So he was at his target pain score, and then we were able to convert him. That's kind of my experience. Everybody's a little different. Bill actually started to take the breakthrough doses. Some of our patients, they just are so resistant. It takes a lot of education for us to get them to take the doses. So that's where my nursing colleagues really help me going into the home, seeing the patient in the outpatient clinic regularly or phoning on the phone, educating, supporting. They could do it in 3 days. Now, if you were doing it intravenously, you would see the control in the same time frame if you use this particular technique, or subcutaneously. Of course, if you're working with Nevenka and her team or another palliative care expert, we have other techniques to move a little faster. But the basics are kind of 2, 3, 4 days, depends on the patient's pain. And then I can once they have no side effects and their pain is controlled, I can quickly convert them. Does that make sense? Is that similar to your experience, Nevenka?
Yes, it's similar. And there is no need too high to make slow release the second day. It's better to wait to have more constant pain relief, and then you are sure that it will be helpful for the future.
Absolutely. And, one of the things, if I may comment a bit further, that gets pushed, and I've seen it in many countries, is the push to add a fentanyl patch. Well, again, it's a slow release product. Don't put it on any faster. And then what you need to be careful about is the equianalgesic dose between the morphine and the patch. You can't titrate with a patch. So I've had the manufacturer really trying to push me, I should start with a patch. And I refuse because it doesn't give me those test doses. And I've had several patients really get quite drowsy or confused with patches. They're fabulous for maintenance. And what I just need to understand is a 25 microgram patch is approximately 50 milligrams of oral morphine in 24 hours. So there's my Bill, who was taking 400 milligrams. Again, dividing by 50, he would need 8 times 25 microgram as patches.
You also stressed in your lecture how to titrate morphine in patients which are not in good condition, which fragile one. So it is also very important to point that you have to reduce usual dosage.
Right. Well, and the beautiful thing about my technique is you might want to start out a little lower, but that first dose will tell you whether you're having an impact or not. Because if they're naive and they have no history, please only start with a breakthrough. And literally in an hour, you will know whether it's had any effect on the pain and is it safe. So if they're in the hospital and they're sick, you can come back around on your rounds in an hour and a half and see what was the effect. Make sure your nursing colleagues know how to help you. If they're at home, maybe they wait in your outpatient clinic for an hour and you see the effect. So then you can become assured. And, so many times we want to start with 2.5 or 5 milligrams of oral morphine. Rest assured, it's a tiny dose. 5 milligrams of oral morphine is not the equivalent of a 50 milligram tramadol tablet plus paracetamol. It's just like a tramadol tablet. And when I start with patients, I'm usually going to start with 10 milligrams.
We have one question from audience. What
Sure.
if patient cannot wait 3 or more days to get complete pain relief? Can it be achieved sooner?
Well, so if they're at home, I would say no. If you're going to admit them to hospital, then experts like Nevenka, who are very familiar, can use different techniques to potentially move a little faster. But today I was teaching pharmacokinetics, and I want you to understand the pharmacokinetics. The principles are the same with all medications, as I've been trying to illustrate. And then in the hands of an expert and an expert service, which knows how to monitor patients, we potentially could move faster. But that would not be the routine. I also want you to reflect. Patients like Bill have often been in pain for 2 or 3 or 4 weeks. They only come to the doctor when they're finally fed up with it. We're going to get them out of pain in 2 or 3 days. That's pretty fast. Amazing if they could actually do that and do it safely. And so we need to give people that chance to catch up. The other thing I like to highlight is getting people to learn that a breakthrough dose will help them. Really teaches them the value of using those breakthrough, the PRN or the SOS doses afterwards. So a little time spent teaching is not a bad thing. Does that make sense, Nevenka, from your
Yes,
perspective?
of course, yeah. There is another question. How would you get to the required daily dosage using IV morphine or pyritramid? Pyritramid is not good for such kind of pain, but can you illustrate the protocol for
Right. So you use the same protocol. The only difference is the IV is hitting Tmax in 15 minutes. So now we've got there after an hour, after 15 minutes, we know where we are. If we're just using breakthroughs, we can offer another breakthrough every 15 minutes, but somebody has to be there at the bedside monitoring. And I recommend the doctor passes by to see if everything is really safe. But you could offer a dose every 15 minutes, couldn't you? In those initial doses. And then if we're going to dose routinely, IV, it's still once every 4 hours. And it will take 5 half-lives to get to steady state. So those are, and again, if you're not familiar with this, and I know we're talking to an audience across Slovenia, you may want to have a palliative care colleague who really guides you the first few times you do that.
Do you have written information for patients who are out of hospital, or it depends only on phone controls in the time of titration?
Well, you know, I mean, we do, and there are many booklets that describe it, but I think it's so useful to write out very specific instructions for each patient. That's my personal preference. I get my nursing colleagues to do that so that I'm using the actual tablet sizes, and you can begin to see that if we start to have immediate release and extended release products, those are 2 different types of tablets. We need to make sure there's clear markers on the bottles, or are our nursing colleagues pre-pouring the medications for the patients into those medication dosage dispensers. Again, we need to be very careful about this. Patients get confused once we start to introduce 2 different formats, and somebody needs to be watching to make sure they're not getting into trouble. So I customize the instructions for each person. What do you do, Nevenka? Do you do similarly?
Yes, the same.
These are great questions.
In this moment, there is no other questions, so we can continue with. Do you have another lecture for us?
No, I do not.
You don't? Okay. Then please ask Dr. Ferris something more.
2 more quick questions in the Q&A, it says. I don't see them in the chat.
There is something. Okay, I will look it.
I don't see the Q&A, so I see the chat.
When you're treating an opioid-naive patient with very severe pain, would you start with an oral morphine or rather the IV boluses?
But it depends a little bit on the setting of care.
Yeah.
So I would, if I have somebody with very severe pain, I would personally attempt to have them hospitalized, and then I would be treating them with IV doses every 15 minutes to see what the routine should be. And that will really help me get them under better control. In a hospital setting, I also have access to what's called patient-controlled analgesia. So I have the ability to set up a pump where the patient can actually push the button. I believe you also have those kinds of pumps, do you not, in Slovenia? So patients can push the button. Is that correct?
Yes.
Yes, I thought so.
Okay.
So again, but those, you want people to have a bit of experience with that, don't you?
Not exactly. One another question. When changing medication from tramadol to morphine, is it okay to stop tramadol suddenly after the patient received morphine, Or should we expect some kind of tramadol withdrawal, and it's better to reduce tramadol slowly?
No, you can stop it abruptly. You give the patient a dose of tramadol, you get them organized for the morphine, and at 4 hours, you can give the replacement dose of morphine. Remember, it will take 5 half-lives for the elimination of the tramadol. It's going to take 5 half-lives for the accumulation of the morphine. So there will be some crossover. As long as they're not having side effects, it'll be perfectly safe to stop the tramadol. You know, it's not as though they withdraw very suddenly.
Okay, there is nothing in the moment, so it's my turn again. In the era of precision medicine, how realistic it is to individualize opioid therapy based on genetics, metabolism of patient and characteristics in such sense? Do you believe to this medicine?
No.
No.
You know, I think we're going to personalize with the technique I'm describing. We don't know. So the point that I think that you're getting at is everybody has different kinds of opioid receptors in our bodies. There are variabilities. Everybody has different numbers of opioid receptors. We have different affinities for the opioids. And we don't know. So I'm going to use Nevenka, you're sitting there as my example. We don't know what you have and we don't know what I have. So the first issue is, will our gold standard morphine work for both of us? We won't know until we try. Some patients are quite susceptible to the side effects that come with morphine, others not at all. But we'll find out when we try. If they get a lot of side effects without great analgesia, and by side effects I mean the drowsiness, the confusion. Don't think of the constipation and nausea this way, because those are very specific mechanisms that come with our interactions and side effects. And everybody's going to get constipation, and everybody is at risk of nausea. We'll prescribe medications for those. But we don't know till we try. And then if we get side effects with a particular medication, we potentially need to rotate to a different one, which has different stereochemistry, maybe different opioid receptor affinity, and we will see how effective ultimately that opioid is. So we just don't know enough about this. We know that there is pleomorphism of the opioid receptors and the affinities, but we don't know how much it is.
Okay, thank you. There is question, what for patients who cannot take morphine perorally, what to do, how to titrate it?
Where are these
Who
patients?
cannot swallow tablets.
Pardon me?
For the patients who cannot swallow tablets, which cannot
Sure.
be perorally.
So do you have a liquid format of morphine available in Slovenia?
Yes.
Yes, so you could mix that with other liquids the patient can take. But let's assume the patient has complete dysphagia and they might be aspirating. Then you want to go to a different format. Again, we could administer these medications subcutaneously, and we can do that very safely in the home setting. It takes a level of skill, there's no question. We need to teach families, but I've spent my whole career teaching families, and just like people can easily give insulin at home, people can often easily learn to give morphine at home. It can be a very small needle. We can place a subcutaneous needle with an injector port, and we can use the same injector port again and again and again. It's quite easy to teach families how to do that. And those subcutaneous needles, if you're watching the needle site, yes, our nursing colleagues frequently have a ritual of changing them every 3 days or so in the hospital. They don't need to be changed. I only change them if they get red, or they get red at the needle site, or they're leaking. We've had some patients who can have a needle in place subcutaneously in place for 14 or more days. So again, it becomes very practical to do it at home. And we can teach families how to change those needle sites as well.
We have the same experience using this continuous subcutaneous infusion. And for titration, we are also using this kind of subcutaneous needles.
Excellent.
Nice, Frank. We are coming to the end of our session. I will ask you the last question. If you could give a piece of advice to the next generation of palliative care physicians about opioids, what would it be?
Please learn the science, learn the pharmacokinetics, and learn the science of doing careful assessments. We need to establish the cause of the pain that we are treating. We need to understand, is it nociceptive? Is it neuropathic? Is it mixed? What is the cause? We need to understand, and of course, I did not talk about that today, different medications can be helpful in different situations, and opioids are not for everybody, particularly musculoskeletal pain, which can be associated with advanced cancers. Musculoskeletal pain responds very poorly to opioids. And if you think about the neurophysiology of pain, we get that peripheral receptor, which is stimulated. The first response is through an arc that causes muscle contraction. That doesn't go away with advanced disease. There's still muscle spasm. So please, again, focus on the cause, learn to do careful assessments, and as you're prescribing, follow the pharmacokinetics for all the different medications we choose. It takes time, but we have the science. And then it takes experience.
Thank you, Frank. We are very glad, really, and happy to have you with us. Thank you for such nice lecture, and I hope we will meet again very, very soon, and to see you also here, eye to eye.
We like the eye to eye, don't we? We like that.
Almost. So with this, we will close this session. Problem of pain relief is really very deep, and we just touch one part of using opioids in this big picture. And I hope that we can do other particles to make more common approach to pain relief and to help our patients as much as is possible. Thank you, Frank, again, very much, and see you soon.
See you soon. Cheerio, and thank you to the medical chamber for hosting us.
Hvala vsem vam, ki ste zdržali tudi do konca. Materiali bodo dostopni, tako da se oglasite na zbornico, da boste jih lahko dobili. V glavnem bo vse v pisani obliki in različne tabele, ki jih je Frank pripravil, so res dobrodošle v vsakodnevni praksi. Hvala za pozornost in lahko noč.